Welcome to this explainer. When most of us think of a burn, we picture a static injury, right? Like a bad scrape or a cut that happens, stops, and then just needs time to heal. But medically speaking, that couldn't be further from the truth. Actually, a burn is a living, evolving physiological crisis. It's this highly active battlefield where cells are dying, fluids are shifting wildly, and honestly, the decisions made in those first few hours can literally mean the difference between a full recovery and permanent, devastating tissue loss. So today, we're unpacking the incredible science of burn wound management, where every single minute and every clinical intervention absolutely counts.
Okay, let's dive into this. We're going to methodically tackle this dense topic step by step. So here's our cognitive roadmap. We'll cover the skin's crucial shield, classifying burn depths, the zones of injury, critical initial wound care, escherotomies and releasing pressure, and finally, treating specialized burn areas.
Starting right off with Section 1, the skin's crucial shield. To really appreciate the devastation of a burn, we first have to respect what's being destroyed. Our skin isn't just some wrapper, it's a highly complex, multi-layered organ. You've got the thin outer layer, the epidermis, and beneath that the much thicker dermis, which houses your hair follicles, sweat glands, and nerve fibers. Together, these two layers perform 5 absolutely vital functions. They protect us from infection, they act as a watertight seal to prevent massive fluid loss, they regulate our core temperature, they provide our sensory connection to the world, and they produce vitamin D. When a burn strips the shield away, the body doesn't just lose its armor, it loses its thermostat, its moisture barrier, and its primary defense against invading bacteria. So the stakes, they are incredibly high.
Let's move to and see how this builds in Section 2, classifying burn depths.
The escalation of thermal damage happens in very distinct stages. A first-degree or superficial burn, think of a standard sunburn, only hits the epidermis. It's red, it hurts, but it peels and heals in days without scarring. And because it's so superficial, it's actually not even included when doctors calculate the total body surface area, or TBSA, of a burn for fluid resuscitation. Now, second-degree or partial thickness burns break into the dermis. This is where you start seeing wet, weeping blisters. Then we hit third-degree. Full thickness. The entire epidermis and dermis are wiped out. The wound turns white, brown, or charred black. And crucially, it forms this dry, leathery, coagulated tissue called eschar. We're going to talk a lot more about eschar shortly. Finally, fourth-degree burns plunge straight to the skin entirely, destroying underlying fat, fascia, muscle, or even bone.
Now, understanding depth is vital, but here's a fascinating question for you. We know how deep burns go, but what happens to the tissue right around them? As it turns out, a burn's depth is only half the story. Which brings us to Section 3, the zones of injury. To understand the surrounding tissue, we have to look at a concept described way back in 1947 by a researcher named Jackson. Think of a localized thermal injury like a metaphorical bullseye. Jackson identified 3 distinct zones. Right at the dead center, where the heat contact was longest, you have the zone of coagulation. The cells here have suffered coagulation necrosis. They're completely dead. Surrounding that is the zone of stasis. Here, cells are injured and blood flow is severely decreased. But under the right conditions, this tissue might actually be saved. Finally, the outer ring is the zone of hyperemia, which has the least severe injury and will usually recover over a week or so.
But that middle ring, the zone of stasis, is sitting on a ticking clock. If a patient with a large burn doesn't receive optimal fluid resuscitation and wound care, that struggling middle zone will begin to die off over the next 24 to 48 hours. The critical window to save that tissue closes fast. While the outer hyperemia zone bounces back in about 7 to 10 days, that middle zone is just teetering right on the edge of permanent destruction.
So, the crucial point is a terrifying phenomenon known as burn wound conversion. If the patient suffers from poor fluid management, localized hypothermia, or gets an infection, the blood vessels constrict even further. That delicate zone of stasis dies and merges with the dead center. The burn literally grows in size and depth. What started as a partial thickness burn that could have healed entirely on its own converts into a full thickness injury that now absolutely demands surgical excision and skin grafting.
Moving on to Section 4, critical initial wound care.
Knowing that the burn is actively trying to expand, the very first step is pre-hospital cooling to launch an immediate counterattack. You want to stop the burning process immediately by removing clothing, jewelry, and applying cool tap water for up to 30 minutes. This relieves pain and, more importantly, it might actually save that fragile zone of stasis. However, notice the strict 5% rule here. This cooling is only recommended for burns covering 5% or less of the total body surface area. Why? Well, with larger burns, the patient has lost so much of their skin's temperature regulation that dousing them in cold water risks massive systemic hypothermia. And as we just learned, hyperthermia causes blood vessels to constrict, which kills off the zone of stasis.
Once at a medical facility, if the patient isn't being immediately transferred to a specialized burn center, the triage protocol is highly specific. First, pre-medicate for the intense pain, keep the room warm, and wash the wound. But here's a quick clinical pearl. Never use the common antiseptic chlorhexidine near the eyes or ears. Next, medical staff will gently debride or remove blisters larger than 2 centimeters and apply a topical antimicrobial. Finally, the dressing. You apply a primary nonstick layer right against the wound, followed by a secondary absorptive layer, and I want to heavily emphasize the word loosely here. That secondary layer must be loosely secured with rolled gauze or netting. Never use compressive dressings on a new burn. Let's see exactly why.
This brings us to Section 5, Escharotomies and Releasing Pressure.
This is where we encounter a terrifying complication that arises when the body's massive inflammatory response collides with that dead third-degree skin. Remember this term? Eschar. It is the dry, leathery, coagulated, dead skin resulting from full-thickness burns. Because it's completely dead and cooked, it has entirely lost its elasticity. It cannot stretch. It is essentially a rigid, inflexible hard shell.
And this brilliantly illustrates the lethal danger of eschar. Because of the burn, capillaries become highly permeable and massive edema leaks into the surrounding tissues. Now, imagine a full-thickness burn going circumferentially around a limb or the chest. The underlying tissue swells, but that leathery eschar shell refuses to stretch. It acts just like a medieval tourniquet. The pressure has nowhere to go but inward. On the chest, the lungs literally can't expand. On a limb, blood vessels are crushed, pulses vanish, and the limb begins to die. The heroic fix here is an escharotomy, surgically slicing longitudinally right through the dead eschar to allow the underlying tissue to finally burst open, release the pressure, and breathe.
It's really important to draw a sharp contrast here for medical accuracy. Eschar constriction is a surface-level shell problem, and it's fixed with an escharotomy right there on the burn unit. But if massive fluid resuscitation or maybe an associated electrical or crush injury causes pressure to build up deep inside the investing fascia of the muscles themselves, well, that is called compartment syndrome. That requires a much deeper surgical procedure called a fasciotomy, which absolutely must be performed in an operating room.
Let's move to our final section, treating specialized burn areas.
As we wrap up, we need to shift our focus to specialized anatomical areas because burns on the face, hands, or feet require completely unique triage strategies to prevent permanent disability. The face has a massive blood supply and loose tissue, meaning edema here is explosive. It's totally common for a patient's eyes to swell completely shut for days, so you must instantly elevate the head 30 to 45 degrees. Eye exams, using copious flushing and fluorescein drops to check for corneal damage, have to happen instantly before that swelling takes over. And definitely avoid steroid drops. For the ears, check the tympanic membrane early, especially if there was an explosion, and absolutely no pillows. Letting the patient use a pillow can severely damage that fragile, burned cartilage.
For hands and feet, elevation above the heart and hourly active motion, if the patient is awake, of course, are critical to forcing that fluid out and saving motor function. You also have to monitor those pulses constantly to catch that eschar tourniquet effect we talked about. And in cases of severe full-thickness burns to the perineum or genitals, a Foley catheter must be inserted early. The intense swelling will physically clamp the urethra shut if you don't secure that pathway early on to prevent devastating urinary blockages.
Finally, I want to leave you with this surprising, really counterintuitive medical protocol regarding roofing asphalt and tar burns. Roofing asphalt is applied at up to 500 degrees Fahrenheit. That's 260 degrees Celsius. It holds heat incredibly well, causing extremely deep burns. But when a patient arrives covered in this hardened tar, the medical emergency is not peeling it off. If you peel it, you'll rip the underlying skin right off with it. No way. Instead, you cool it completely with cold water to stop the burning and then generously apply a petroleum-based ointment, like Vaseline. Over time, the petroleum safely and chemically emulsifies the tar, allowing it to be wiped away gently later at a specialized burn center.
Which brings us to our final thought. A burn truly is a living, evolving physiological crisis. The skin is a vital organ, and when it's breached, the clock starts ticking immediately. From managing that delicate zone of stasis, to preventing the suffocating grip of eschar, to navigating the precise protocols of specialized areas, every single move matters. Will the next intervention save that fragile tissue, or will a misstep permanently convert it into a deeper disaster? The precision of emergency medical management really does make all the difference. Thank you so much for joining me for this explainer, and keep learning.